everyone. Thank you so much for joining us and by us, I mean me, because many people are off at our office this week because of the spring break holidays. But I appreciate y'all being here today for our webinar, Arkansas's Maternal Health Crisis. I'm Rebecca Zimmerman. I'm the Community Engagement Director at Arkansas Advocates for Children and Families. I've been here almost 8 years, and our organization has been around for almost 50 years. I think we look great for our age. We were founded in the 1970s by a group of people who were really active at the state capitol, but they didn't see people there advocating for the interests of children. So they started an organization first to advocate on issues around juvenile justice and child welfare. But it quickly became apparent to them that if they want children to do well, their whole family has to do well. So we've really expanded out the issues that we work on to just about everything you can think of, though not everything, impacting kids and families. We work on pre-K through 12th grade education. We advocate around issues around family economic well-being, food security. We advocate on issues around equity and immigrant families, voting rights. We also advocate a lot on healthcare and healthcare access issues. And we still advocate a bit on juvenile justice and sometimes child welfare as well. We have policy experts here in our main office in Little Rock who do research for us on issues impacting kids and families, what the biggest needs are, and what potential policy solutions that there are to solve those problems. We also have a full-time lobbyist on staff, and my job at Arkansas Advocates is to get as many people speaking up for the well-being of children at the state capitol as possible. We also have a satellite office in Northwest Arkansas and Springdale as well. So after talking a bit about us, let's get into a report that we recently released by the same name as this webinar, Arkansas's Maternal Health Crisis. I will say, because it's just me today and I don't have any tech support, I'm going to take questions at the end just to make things a bit easier. You can put them in the chat or the Q&A and I'll answer them at the end. And if I don't know the answer, I know people who do and I'll follow up with those answers in the follow-up email. We also have closed captioning available at the bottom of our screen if you just click the closed captioning button. And again, if you're just joining us, I will send the slides, the webinar recording, and the report to everyone who registered after this event. So why and where? So this report that we did is based on a series of 4 focus groups that we did around the state. And just to give you some context of why we felt we needed to do these focus groups on the state of maternal health care in Arkansas. So I'm sure many of you on the call know Arkansas has one of the highest maternal mortality rates in the country, 97.6%, 97.6 women die per 100,000 live births. The national average is 32.9 births per 100 deaths per 100 live. That 100,000 live births, sorry, is a lot of numbers. So you can see that it's significantly higher than the national average. Arkansas has something through the Department of Health called the Arkansas Maternal Mortality Review Committee that looks at all of the pregnancy associated deaths. So that in the state, so that means deaths during pregnancy and then a year after giving birth, and trying to figure out why those women died. And they found that most of the maternal deaths that we see in our state, the overwhelming majority, 95% of the deaths were preventable. So another really important reason to have focus groups with women who have recently given birth or are pregnant. We also see some really stark racial disparities in terms of the maternal death rate. You can see here Black women, their maternal death rate is much higher than the statewide average at 146 deaths per 100,000 live births. And then it was even higher for Asian and Pacific Islander women, 198.3 deaths per 100,000 live births. And the time period for those statistics was from 2018 to 2021. Another important reason why we felt the need to do this report was the fact that 45% of Arkansas counties are considered maternal health deserts. So that means they don't have a birthing center or access to maternal health care physician. And so you can see and on this map, the lighter the color, the less access to care that county has. And the lightest color are those counties that are considered maternity care deserts by the March of Dimes. So we have quite a few counties that really are struggling to get that care that the pregnant women and women who have recently given birth need there. So based on that information, and the fact that we've seen a huge increase, and I'm sure everyone on this call has seen the huge increase of discussion at the state level with decision makers around how can we address the maternal health crisis that we're seeing. They've had working groups that have met around the state, panel discussions, things like that. But something that we noticed when we attended those meetings was the voices of women who are pregnant or had just given birth were really left out of those conversations. It was really the decision makers and the policy experts that were there, but not the women themselves. And so we thankfully got a grant from the Blue and You Foundation to host a series of these 4 focus groups. And based on the, like I said, the information I just discussed and a little I'll discuss in just a second, we decided on 4 kind of target groups and areas for the focus groups. So first, Black women and Marshallese women, based on those disparities that I talked about before, both of them have maternal death rates much higher than the state average. We also wanted to focus on the Delta. If you saw that map before, a lot of the counties in the Delta region do have low access to care. So we ended up picking Chico County and Phillips County. Both those counties have the distance to a birthing center is about 45 minutes to 51 minutes. Both Chico County is considered a maternity care desert. Both of those counties have a high number of babies that are born with low birth rates. Both of those counties also have a high chronic health burden. So that means there's a high percentage of people in those counties with at least one chronic illness. And then both of those counties also have a majority Black population. Like we said, we wanted to make sure we talk with Black women in our report. And then finally, we also did a focus group with women with substance use disorder because the Maternal Mortality and Review Committee found that substance use disorder is a major contributing factor to pregnancy-associated deaths. And so pregnancy-associated deaths, that's deaths from up to a year after giving birth. And pregnancy-associated could be directly or indirectly related to giving birth. There's an umbrella, but in terms of this report, Maternal Mortality Review Committee, pregnancy-related deaths are directly a cause of pregnancy. The substance use disorder would be that broader category that happened within that year after giving birth, but it's not directly related. So getting now into what the women themselves talked with us about and what they found important. So in 2023, 41% of births in Arkansas were paid for with Medicaid. And so it's really important to talk about and think through Medicaid when we're looking at the state's maternal health crisis. And so there were a few different issues that really floated to the top across all of our focus groups. One was discussion of pregnancy Medicaid. So in Arkansas, there's different types of Medicaid coverage. And there's one called full pregnancy Medicaid for citizens in Arkansans who are pregnant. And I know full pregnancy Medicaid sounds a little weird, but it just means you have the full range of Medicaid benefits. Everything Medicaid could potentially provide is provided under pregnancy Medicaid, things including like dental care. And the women that we talked to were really who had pregnancy Medicaid. Not all of them were enrolled in pregnancy Medicaid, but those who were really appreciative of the program. They talked about how they didn't have to worry about getting anything paid for when they went to the DHS office and told DHS that they were pregnant. They really helped them like immediately get enrolled and get everything taken care of. And it was just a really easy process to get on pregnancy Medicaid. Not everyone we talked to, like I said, was enrolled in pregnancy Medicaid. Some of them didn't even know that that was one of the Medicaid options, but other women in the focus groups really recommended that they go and get enrolled in that because it's such a comprehensive program that covers so many different needs. And you can see here how this impacted this woman, how easy it made her care. But unfortunately, there were some issues for women in maintaining their health care coverage, their Medicaid coverage. So in Arkansas, for pregnancy Medicaid, you only get it for 60 days after giving birth, where we've already established that you can die from pregnancy-related causes, pregnancy-associated causes for a year after birth. Many other states have, well, all other states except Arkansas have opted to extend that coverage past 60 days. Arkansas hasn't. But what is supposed to happen in Arkansas is after that 60 days has run up, women are supposed to be moved to other coverage options, either other forms of Medicaid, or they're supposed to be moved in the Affordable Care Act plans, on Obamacare plans. But we found that that wasn't always the case. Several women have told us that they were cut off of coverage after giving birth. They either sometimes didn't even know what happened until they went to the doctor trying to get some sort of treatment. And then once they were kicked off, it was really difficult to get that coverage back. You can see this one woman here talk about how She had a lot of trouble getting back on, and she had trouble getting to the doctor for those postpartum visits. We actually did another focus group yesterday, not specifically on pregnancy, but on Medicaid in general. But several of the women there had recently given birth on Medicaid, and one woman told us she didn't even bother going to her follow-up appointments because she knew she had gotten that the coverage only lasted 60 days. And she said that, the last thing she was thinking about when she had just given birth and was recovering and raising her new baby was thinking about going on and filling out this paperwork and things like that to get a different coverage option. Some other things that were mentioned in terms of Medicaid in our focus groups. So in our focus group of Marshallese, Arkansans, and Northwest Arkansas, the women told us that they've received some poorly translated materials from Medicaid and DHS. Specifically, we were told that the person who translates those materials isn't a native Marshallese speaker, and that has caused some significant errors in the translated materials that they receive. We've heard some of our local partners even say that they don't use those translated materials. They'll translate it verbally from English materials that they have. For instance, during the unwinding of Medicaid, was it last year or the year before? It's hard to keep track of time, but they received a letter that instead of saying, we need this information to make sure you're still eligible, they received a letter that said, "You've lied, so we're kicking you off of Medicaid," essentially. And so that obviously really scared people, and that's not what they meant to translate, but that's how, just because it wasn't a native speaker. I think DHS is trying to rectify this and do a contract with native speakers, and so hopefully that will be rectified and those materials will be more accurate. We also heard some issues around billing. So specifically in this series of focus groups, again in that focus group with Marshallese women in Northwest Arkansas, they more than one of them had received a bill for their epidural, which should be covered under pregnancy Medicaid. Seemed like maybe it's a coding error, something like that. But that kind of, and I'll jump ahead, gets to multiple women across the focus groups talked about how they'd like more education regarding benefits and what all is covered and what all isn't covered. And obviously things like billing issues might be addressed if women knew, okay, epidurals are covered, let me call the hospital and tell them like they need to fix this and resend it to Medicaid. But without that information, obviously they were unaware and they thought Medicaid just didn't cover it. Dental coverage was also a big wish for people in the focus group we did with women with substance use disorder. And I will say that the focus group was done at a treatment program called Specialized Women's Services, which is a really wonderful program that allows women to stay with up to 2 of their children in that program. The program provides childcare and things like that. And they're able to live with their children on site as they get the treatments. But dental coverage was something really important to them. And some recent data shows that only like 41% of pregnant women in 2021, I think it was, received dental cleanings or got dental cleanings. And so that is for any dentist or oral health advocates on the call, pretty significant issue because that can cause a lot of problems. But people who did have the full pregnancy Medicaid are able to get that dental coverage was really appreciative of that. So, moving on to quality of care, really boiled down this portion of our discussions into, I'd say, these two big buckets of communication and respect. So, and I will say also, I think this was one of the issues women talked about most, was the quality of care that they receive from uh, uh, medical staff, nurses, doctors, etc. Um, so in terms of communication, we heard what can go well with good communication and what can go badly with poor communication. So in terms of good communication, we heard women talk about how, for instance, one woman, her baby, after she gave birth, her heart rate was dropping rapidly, the baby's, and she's really afraid. But the nurses and doctors explained exactly what was happening, exactly what they were doing with the baby, and that gave her a lot, even though she was still obviously really afraid, gave her some level of calm in that situation. We heard from another woman who had preeclampsia, and her doctor talk with her through that process and what was happening, and then that also gave her a level of reassurance. But on the opposite side, we heard some women go through some pretty traumatic situations because of poor communication with medical staff. Another woman had preeclampsia and eclampsia and wasn't told by her doctor that she did. She didn't find out until she went to the emergency room throwing up blood, was obviously horrified. And then the emergency room staff told her. And she just wondered, why didn't the doctor tell her and get us on some sort of treatment plan for that? Another situation, one woman was telling us how she told her doctor over and over again she didn't want an epidural, she didn't want an epidural, but the doctor, she said, pressured her into getting an epidural, and the epidural wasn't even properly administered, and it just fell out of her back. So that was also in that situation of poor communication with the medical staff. But just to share a few quotes, um, here that the woman was just saying, like, what we all I think want, for our doctor, for them to sit there, act, and actually be interested, make sure you can share all of your concerns, and really feel listened to. Another person, though, said down here in the Delta region, they just want to get you in and out, and obviously don't feel listened to. And we've all probably had that feeling too when we've gone to the doctor. And it makes a really big difference when you're in such a vulnerable medical situation as being pregnant or just having given birth. Another issue under quality of care that I want to talk about is treatment of women with substance use disorder. We heard from a lot of women that they felt judged when they went to the doctor, and also they were afraid to go to the doctor. You can see this. One woman was saying that she expected to be judged when she went to the doctor because she knew that drugs were in her and her son's system, but the doctors could have done, and the medical staff could have done a little bit better job hiding their feelings and just focus on taking care of her and her baby. But we also heard some people with substance use disorder talk about having good experiences. For instance, one woman told us she went to UMAS, and UMAS doctors were empathetic and provided her with a lot of information and resources that she needed, while she was trying to overcome her substance use disorder and also go through her pregnancy. And there was also a lot of conversation within the focus group about in terms of fear of disclosing your substance use disorder, but also knowing that you want and need treatment. Uh, there was a lot of discussion about how to go about that, and I think they didn't really land on something that would make people feel really safe and comfortable disclosing that. Unfortunately, people had different ideas that, like, if mandatory drug testing was required, then the doctors would know and they could share information, but at the same time, people might not go to the doctor at all because of that. Um, a few other things I want to talk about briefly was a lot of the women dealt with some serious medical issues. So for instance, particularly in our Delta focus groups, we heard quite a few women talk about how they received C-sections as part of their pregnancy. And one woman even suggests, like, I think the doctor's maybe just doing this for money. And looking at some research from Arkansas Center for Health, Arkansas ACI. I have it written down somewhere else, but from ACI, let me read you these numbers because I couldn't remember them off the top of my head. That's scary. I said "our" my head. Nationally, the C-section rate is 33.5% of births. In Chico County, it's 42.8%, so significantly higher. And then Phillips County still higher than the national average at 38.1%. We also heard from one woman that she had a clogged milk duct, and the medical staff, she felt, kind of ignored her concerns till it got to the point where she had a medical emergency and had to have serious surgery to deal with that issue. We also had one woman tell us that she had 3 pregnancies. Each pregnancy she had eclampsia, so she wanted to get a tubal ligation, like also called tubes tied, but her doctor tried to pressure her out of doing that, which she also really didn't appreciate. In terms of doulas, a lot of the women we talked to didn't even know what a doula was, but for those a few that did, they really liked the ideas of doulas and wish they had had a doula. UMAS recently released a report, though, that there's fewer than 50 trained doulas in our state. And right now, Medicaid doesn't cover doula services. And then finally, on specialized women's services, that is that substance use disorder treatment program that I talked about. And the women in that program really loved it, really appreciated it, and wish there were more programs like that around the state so even more people could participate. Access to care, again, I think there were 2 overarching ideas here, too far and too few. And Arkansas Center for Health Improvement, which is what ACI stands for, I apologize before, um, has a couple really helpful graphics that I wanted to share with you before I get into what the women talked about. So you can see this map that they created here. In each county, you can see the average or the median travel distance to delivery facilities. And so you can see, like I mentioned, 45 minutes in Chico County, 51 minutes in Phillips County. There's a lot of places in the state where you can get there really fast. But there's a lot of places in the state where there's still a long travel distance to get to birthing facilities. Another helpful map, so that was too far, and then this one gets to that too few. You can see that we only have 33 birthing hospitals in the state. So this was especially an issue with the women we talked to in the Delta region. They felt that there was just too few doctors that they could access. And actually, quite a few women went across the state border to give birth in Mississippi and get health care in Mississippi. Because that was closer. But some of the women that did receive care in Arkansas talked about having too few doctors. There was one doctor in particular that they had a conversation about in one of the focus groups where one woman had given birth over a period of time many years ago to one baby and just recently had a new baby and had the same doctor both times. And she noticed a change in what she perceived his quality of care from when there used to be more doctors, OBGYNs in the area to now where he had a lot more patients and she felt like he just wasn't as good of a doctor now just because he was overwhelmed with the number of patients that he had. Um, and then we talked too about too far to doctors and hospitals. And this, we heard some pretty uh, serious stories. For instance, one woman on her way to give birth, she was in ambulance and she gave birth to her own baby. She said she just reached down and grabbed the baby because she went into labor on the way there. The ambulance uh, worker was sitting next to her at the time, and that's how she gave birth. Another woman told us she had a medical emergency while she was pregnant and had to be sent to Memphis to get that taken care of. Another woman told us her husband was speeding to get to the hospital when she was pregnant, and the police pulled her husband over. The husband explained what's happening, and the police were like, "Follow us," and they got a police escort to the hospital because I guess the police understood too how far it was and how important this was. We also heard a lot about issues around transportation, both the cost of transportation and the time it took to get to medical appointments. So quite a few people, when they had friends or family take them to medical appointments, they were charged. One person said her uncle charged her basically an arm and a leg to take her to her medical appointments. But once and it also took a while to get to the appointments, like I showed you on that map. But once they got there, they could be there for some time as well. And it could take a whole day basically of time for these appointments, getting there, going through the appointment and everything. People also talked about there is transportation provided through Medicaid, and there's some mixed opinions about that. Some people didn't know about that at all and wish they had heard about it and wish there was more promotion of that. Other people felt like there were too few stops or too many stops and things, and it just wasn't really a good option for them. So a few quotes I wanted to share on this topic. We need more medical labor doctors. One was very stark. This was from a woman in Delta. It's horrible to be pregnant here. And this woman said, the time that took for her appointment and to get seen was about 3 hours, which obviously is a huge chunk of your day. So, another topic of discussion was around postpartum depression. I think a lot of us who work on these issues take for granted that this is something that there's a lot of awareness about, but in our focus groups, we found that that wasn't the case. And in Arkansas, we actually have a higher than national average in terms of women postpartum reporting depressive symptoms. And so in Arkansas, it's 19.7% of women, where nationally it's 12.7% of women. A lot of the women we talked to, like I said, this wasn't something that they really thought about while they were postpartum. Some women told us that they were just really focused on their physical health, but in retrospect, they think they did have postpartum depression. Another woman told us she had really bad postpartum depression, but didn't seek care for it. In our focus group with Marshallese or Kansans, we learned that there's some lore in the Marshallese community about a spirit taking hold of women after they give birth, and that lore probably is related to postpartum depression. And in that community, it's really not talked about, and there's not a lot of understanding about this issue. And so it was really apparent that to us that this, just a lot of people didn't know about it or weren't thinking about it. They had other more pressing concerns, just because I think it sounded like the physical ones, physical issues is something they could see and feel more directly and understand more directly than postpartum depression. There were two laws passed in 2023 around postpartum depression. So and they're a pair of laws. So one of the laws required that women 6 months or 6 weeks postpartum need to get their doctors need to provide a depression screening, and then another bill required that Medicaid reimburse for that screening. And I think as a result of this, this one woman quoted, though not everyone seemed to have received that screening. This particular woman felt really cared about by her doctors in Monticello, and felt and they reached out regularly, not just once but weekly, to make sure she was doing okay for several weeks after she gave birth. Another woman, when we were talking about this, said that she thinks everyone postpartum should have a social worker or something that talks to you about how you're feeling, but also why you're pregnant. And she kind of gave the impression that, when you're pregnant, people just kind of write you off and like, oh, you're emotional and things like that, and don't really take how you're feeling seriously. And she felt like it should be standard and care that you get mental health check-ins with your medical team, both during pregnancy and postpartum. And finally, before we get to questions, and again, you can put the questions in the chat or the Q&A, and I'll get to them in just a minute after this section. But women also talked about additional resources that they'd like to see outside of what we talked about before. One idea that we heard about in terms of food security was having a program kind of like pregnancy Medicaid, but pregnancy SNAP, where you get SNAP benefits just for being pregnant, and are able to get those also postpartum as you're recovering and not able to work. We also, with the women who were part of the Specialized Women's Services Substance Use Treatment Facility, they also wanted to see some more resources from Child Welfare Services. Several of them told us that they were unaware that their child was going to be taken away by child welfare services, and their custody would be taken away. And they wish they had been provided more information about that. And then also how the unification process works and what they needed to do for that. People also said that they'd like to see more lactation support, pregnancy classes, support groups with other people who are pregnant or just given birth. We also heard people talk about the desire, especially in one particular focus group in the Delta, about more support for pregnant teens. One woman was saying it seemed like a lot of pregnant teens were isolated in their community and didn't receive support. They received like ostracization. And actually, one woman there told us when she was a pregnant teenager, she was kicked out of her church. And instead of that, they wanted to see people kind of surround that pregnant girl and provide her support and resources and things as she goes through that process. And people also talked about, they knew that some parts of the state did have access to home visiting programs, but they wished that that was universally accessible. And so I'm going to stop sharing so I could see these questions more clearly. One person made a comment that on the map that I showed in terms of, or one of the maps that I showed in terms of access to care, that sometimes in those counties, maybe they have access, but it's very limited. And it may only be one option. Another person made the comment that Medicaid covering midwife assisted home births would help offload some of the client care from the OBs, and has been directly correlated to healthier outcomes. A question, someone asked, does Arkansas have any statistics about potential criminal or DHS reporting of women being charged with substance abuse, losing custody of their children? Actually, in a report, not about criminal charges, but let me pull up those statistics, Sarah. Sorry, I wasn't able to say everything that was included in the report. But in terms of reporting and women losing custody, so from July 2023 to June 2024, the state received 1,360 Garrett's Law's reports, and that's the law under which children would be removed from custody. It says the state substantiated 86% of the reports, and 10% of those substantiated reports, that a child was removed from the parent's custody. And our policy director put that number in faster than I could read it. So thank you, Kristen. Another person asked if Arkansas is going to allow doulas and lactation consultants to get reimbursed through Medicaid. I don't know about lactation consultants, but there has been several bills and potential bills talked about this legislative session that would create I think a licensing system for doulas. And then also, Kristen, our policy director, is on it again. There is one on lactation consultants, HB 133. And then there also has been conversations around allowing doulas to be reimbursed with Medicaid, but I'm not sure if a bill has been filed on that. But if there was, then Kristen's gonna drop it in the chat, I'm sure. But there definitely have been conversations about that. And then obviously some legislation has come up as well, because I think there is an understanding that, there a lot goes into making sure that a pregnancy goes well and goes smoothly, um and and people from a lot of different perspectives have been talking about that issue. Anything else? Any other questions? Yep, Kristen's on it. There is the Momnibus bill, was called Healthy Moms, Healthy Babies Act, addressed the reimbursement for doulas and community health workers. So yeah, and that bill is now law. And she said there's other bills that are coming up about and parameters for doulas and community health workers around the state. Any suggestions for people who would like to help serve with these things? So I think there's a lot of different things that you could do. There's a lot of nonprofits that are becoming more and more focused on the issue around maternal health. Something that you can do even if you're not a maternal health expert. There's a nonprofit called the Arkansas Birthing Project that has a program called Sister Friends. Where you can be paired up with a pregnant woman and help her through her pregnancy and after giving birth, and they train you on how to best support her and make sure you can connect her with resources and things like that. That's a really great program. They also have groups for uh, uh, fathers as well. I know Ujima Maternity Network is starting to not only have that doula component, but also these other community support services as well. I think they're also have started a fathers group too. And I think those are good places to get connected with. There's also organizations that are trying to do story collection projects, including our own around not just, well, ours isn't just about maternal health, but includes maternal health, but trying to get more of those personal stories out to show the real impact that this is having on people, both positive and negative, when maternal health care goes well and when it doesn't go well as well. So I think getting connected with those nonprofits, with the organization, if you know of a story, if you have a personal story, because we talk about in terms of making policy change, you need to connect with the head and the heart. The data is really important, but connecting with a person's heart to change their mind is also really important. And those stories help make that heart connection. Someone on the webinar is going to DC and about to present on pregnancy Medicaid and gestational diabetes in Arkansas. That's really amazing. Glad, so many people are talking about this in so many levels of government. Anything else before we end? Well, I'll send, like I said, a follow-up email with the report, with this recording, with the slides. I'll also share the websites to some of those other nonprofits that I mentioned and a few others too, if you'd like to get connected and learn more. And I'll send it out soon, but really quick, Kristen wanted to clarify that the Healthy Moms and Healthy Babies Act specifically requires that Arkansas Medicaid program shall reimburse doulas and community health workers for home visitation related prenatal care and postpartum care, but not all insurers. So just through the Medicaid, but Okay, well, thank you all so much. Someone asked if they want to be added as a resource. If you send that to me by Monday morning, I'll probably be sending out the follow-up email Monday afternoon or Tuesday. So if you just send me an email, you should have all got an email from me this morning, then I can add you to that list of resources. Okay, well, thank you all so much. I hope you have a wonderful weekend. It's supposed to be a bit stormy in some places, so stay safe and take care. Thank you, everyone.